charitable organization. We are more into development. We have like 22 programs for all the sectors of the community. And out of this Ambabram, you know, we had like 4 NGOs born from Ambabram service. One of them is Egypt Without Disease, which is now like Caritas Egypt, trying to help in all fields of medical care to the poor people, not only to the Christian, but also for everyone. So if you can see now the vision, that's the old, you know, theme or the vision. All doctors should serve and all patients should be served. The objective is to spread our service call to all Christian doctors, because you may know that I was a doctor one day, and I believe so much in the missionary life of doctors, or the doctor can serve God with his talents, with his career, much more than anyone. That's why I believe that all Christian doctors should serve God. Nowadays, medical services are getting very expensive everywhere in the world, and especially in Egypt. So we need to engage everyone to the medical service and to reach all needy patients and serve them with a proper quality. Because when you go to our villages, you can see severe cases and they cannot go to any doctor or any clinic because of their poverty. Nowadays, لا ننسى رجعي واحدة please. We have like fixed dental units. In 6 October, it's one of the dioceses in Giza. We have like 3 units serving like the poor of 6 churches. Masr al-Adima, just one for more than 22 churches, which is, you know, very little when you see like 1 unit only. Al-Mu'attam, another one for 16 churches. Shobra al-Khema, one for 37. El-Giza now is 5 bishoprics, 5 dioceses. So one of them 6 October, the original Giza. We have 2. Gerga, it's in Upper Egypt. It's nearby Sohag. And Gargada, also in Sharqiyya, it's in Bahari, north of Cairo. Next, please. All these like charitable clinics following Ambabram service, or what we call now Egypt Without Disease. Portable dental units, we have also these portable services to go to the tough villages and to try to help people who cannot come to the fixed units. And we have special one for the refugees. We have thousands of Ethiopian, Eritrean, and Sudanese in Egypt. Next, please. When we speak about St. Paul is the service of evangelism. We evangelize in 35 countries, like 23 in Africa and like 12 in Asia. And like 25 of these countries are very poor, and some of these countries are you know, much poorer than Egypt. So the medical missions do miracle there, and they, you know, speak about the name of the Lord easily, and people, thousands of people could know the Coptic Church because of the medical missions. We have like fixed dental units in Namibia, Malaysia, Ethiopia, Ghana, Uganda, Philippines, Kurdistan. And portable now, they go with the mission, so they are, you know, they take them while traveling, serving other countries. كده خلصنا، مش كده نانسي؟ في حاجة تاني؟ That's simply, yeah, some of the photos you may view. Next, please. Okay, my dream is to help everyone to find his mission in serving the poor, either of being merciful to the poor or to evangelize the name of the Lord by serving people. So both directions are needed nowadays. And thank God in the last 5 years, we had like more than 100 dentists shared in the missions outside Egypt, and maybe 3 or 4 times the number serving in Egypt, from Cairo to Aswan to Alexandria. But still we need your help because, you know, again and again, it's very expensive, and the dentist cannot cover all the needs of 100,000 people. And you all know the government cannot cover the needs, especially of the dental care. In Africa and Asia, the need is higher, and some of these people, they had seen the doctor for the first time. Some of them were coming just to see what is this doctor looks like, because they heard about someone called doctor, but they had never seen one. So we had seen like miracles in the mission, especially in the medical missions. And also those who shared in the medical mission, they enjoy seeing the hand of God, and they enjoyed seeing the spirit of the early church spreading everywhere with the love of Christ. So I'm ready to answer any question concerning our service till Sayyidina bless us.
I think Zaydna's actually joined now, Abuna, which is good to see.
Okay,
But,
very good.
yeah, what we'll do is we'll get Sayyidna to talk as well. If anyone has questions, just put them in the chat box and we'll ask Sayyidna and Abuna together anything that you might have. So next we'll get Angaelos to say a quick message. I'm John, for those who don't know. I've had a chance to speak with some of you already on social media. Just want to say thanks to everyone who's joining us today. It's really nice to see, you know, we've got people from all over the world, and you know, we're really happy to see everyone that could come. And we've made a short video as well to show you, which we're excited to show you. So we'll get Angaelos to speak to us just before we show you that.
سيدنا نقبل أيديكم يا سيدنا.
أبونا وحشتنا.
ونيافتك وحشنا أكتر، نقبل أيديك.
كنا المفروض ناخد بركة قدسك السنة دي بس
معلش أنا اللي
unfortunately you weren't able.
Thank you, Sayyid.
It's so wonderful to be with you all. I'm sorry I'm late. I was stuck in London traffic, but it's been a happy day because I've had 3 baptisms this morning.
Thank God.
And a wedding, and then tonight we're actually got a reception service for our first ordained, 2nd generation ordained priest at St. Mark's in London. So it's been a good day, but I'm so happy to be able to be with you in the middle of this, and I'm sorry to be late. I was listening to Abuna and very inspired by the service that Abuna himself does and the servants around him. And it brings to my mind the importance of collaboration. And this is why when I was approached by the group here to you know, floating this idea of the Coptic Dental Society, I was really in awe of it. I'm impressed by it. There's a wonderful team working together, and it's good to see Ashraf on the call as well. And it's nice to see that sense of collaboration. You see, the Christian message is one of collaboration. Once, you know, first of all, even to speak right at creation, it was about God walking in the garden with Adam, God saying it was not good for Adam to be alone, creating a helpmate, giving this model of cooperation, collaboration, this model of unity. And even when St. Paul speaks about what the church is, it is the body of Christ. And we all have our own part to play. And we're all very different. And just looking at, you know, your wonderful pictures here on the screen, You're all very different. You have different gifts. You have different abilities. You have different aspirations. You have different dreams and visions. And when they all come together, that's when we see the beauty, the manifest light of Christ in the world. And we all know that the most important place for light to shine is in darkness. And for you as healthcare professionals, your light shines when people are in pain and need care and need your attention. That's why God has called you to this. You know, just as Abuna and I have a vocation, a calling to ministry, your calling is to medical ministry. It's a vocation, it's not a job. You don't spend all the years you do studying to be in a job. This isn't a job. It's a vocation, it's a calling, it's a responsibility. And, you know, when our Lord is mentioned as the chief physician, when he himself says about his own coming, that he didn't come, that a physician is not there for those who are well, but those who are sick, he puts himself before you so that you can follow in his footsteps. And as Abuna said, and as we've all seen, there is abject darkness of healthcare around the world, in Egypt, but in many other places. We take healthcare for granted when we are here in the UK or otherwise, because it's there, it's available. You know, we'll whine about how slow getting an appointment is, or, you know, how difficult the NHS is, but actually we don't realize that it's there. It's available to us, and there are people who don't have that. And so the two things that I find incredibly encouraging about this initiative, firstly, that it actually brings you all together. Now, anyone who knows me knows I have a heart for collaboration and cooperation. I like bringing people together. I like cooperation. I like drawing on everyone's strengths. Because, you know the expression about the sum of the whole is greater than its parts. You know, you're all very good as you are, but when you come together, you have that collaborative strength. I always tell the story as young, and any sort of deacons on the call, and Abuna, I'm sure, will relate to this, dealing with mischievous deacons. We all came to the realization very early on that as deacons, when you walk around the procession, you hold a candle, it's lovely. But if you put your candles together, you get a really big flame. Now, while that is a health and safety risk in churches, being the light of Christ in the world means that when we put our flames together, no matter how small they are, they become a huge flame. And I think that's where this work comes. So anything that brings people together, I am 1,000% on board on and for. And that's why this initiative has my complete backing and support. And I'm really looking forward to working alongside of you. The second reason is because there is a great need. And when we put you together, you can fulfill the support and provision for that need in a very, very useful way for many people around the world. You know, I've seen the need in Egypt. I know the need in Egypt. We do humanitarian work in Egypt. And just something exciting, slightly premature, but I'm going to tell you anyway, just as encouragement. Only a couple of days after I had my conference call with the team, I was approached by someone who was going to do work in Egypt. And they said, we're looking for collaborative programs. And I said, I've got just the one. And I floated this program of the dental care clinics, the mobile clinics, and they seemed interested. So we may already have someone who wants to input and to support. Because when people see us shining our light, they want to be part of it. So I'm really, really happy to be with you. I know this will go from strength to strength. It'll be a blessing for you, because don't forget, when we serve, we're the first recipients of blessing. This isn't just about what we do for others. It's about what happens to us, because our God is faithful and generous, and he provides to those who give faithfully. I'm not talking about money. I'm talking about your health, your gifts. I'm talking about you being well-rounded professionals. You know, many of you have just started. Some of you are on your way. Some of you are very mature and established. And that's why we have this continuity of care, continuity of vision among you all. So that I've just hung up. I want to first thank you, first and foremost, for being part of this. And I promise you that whatever I can do, as little as it is, you have my support, you have my backing. And that doesn't mean sitting and praying for you, although we're all supposed to be praying. But we all pray for each other, but we also all get in there, roll our sleeves up, and do as much as we can. Finally, I don't know if you can see behind me, it's a very interesting icon of Joseph, St. Joseph. I love that icon. It's an icon by Fadi Mikhail, who's one of our iconographers here. I love that icon because Joseph was righteous, but he was faithful. And it looked like he went through horrific situations and, complication after complication. But at the end, he was in the right place to do the right thing, and he helped the people of God. And so where he was addressing famine, we are looking to address healthcare needs. And so we have so many models in scripture, from God himself to the incarnate word, to his saints and his righteous people. And we have so many models that we can follow. But above all, the most important thing is I'm incredibly proud of you all, because you are that mosaic of the image and likeness of God. Individually, but more importantly, you are that mosaic collectively, because you provide that light in the world. So yes, as Abuna said, any questions to him and or to myself, I'm more than happy to be here with you. We are going to, I'm going to leave, because once Ashraf starts to speak, I'm not going to understand anything. So rather than sitting here and looking vacant and blank, I'm going to leave you do the dental things that you guys understand. And I've got to say, growing up, I really hated dentists, but I'm getting to love them more, because I had braces and my orthodontist was a sadist and he liked inflicting pain. But I'm sure that's not the case for all orthodontists. So I have repented my hatred, and now I love dentists, especially the ones on this call. And so once Abuna finishes and we finish our bit, I'll leave Ashraf to mesmerize you with his knowledge, and I will go do other things that I'm better at.
شكرا يا سيدنا. أنا عايز أخذ بركتك كنت.
لا يا أشرف.
ميرسي خالص.
Thank you, Sayyidna, for that lovely talk, and thank you for joining us. Next up, we have a video introducing the society.
Thank you, John, for that. I hope that was useful for everyone. We'll be providing all the emails and contacts at the end of today's session. I also want to thank Abuna Daoud and Sayyidna for your lovely words. And we're really, really grateful for your sort of efforts and support with this. Next, I would like to introduce our colleague, Mr. Ashraf Messiha, who is a duly qualified oral maxillofacial surgeon at St. George's Hospital. He's got vast sort of surgical experience in the field, and he has a specific interest in facial deformity and TMJ, I believe. He's kindly agreed to speak to us today about some interesting cases that he's sort of seen along his journey as a consultant. I'd also just like to say, for anyone who's got any questions, either for Ashraf or for regarding the charity, please just message on the chat and make sure it's available to everyone so that we can ask the questions at the end, and we'll go through all of the questions at the end of today's session. Ashraf, you're welcome.
Thank you, Christy.
No worries.
Thank you. I'll share my screen, shall I?
Please.
Okay, thank you very much for this lovely introduction and lovely words by Sayyidna Angaelos and Abuna Daoud. And I'd like to first of all say thank you to Rafi, Mariam, John, Andrew, Christine, Nancy, and anybody else I forgot to mention. But it's a wonderful initiative taken by you all in order to help others. I thought of, when I got invited to speak about dentistry, that it is something I left some 30-something years ago. And I thought, gosh, what am I going to contribute without any slides of teeth? So I got a little bit taken aback when Rafi asked me. And he said, no, don't worry, just don't show any blood. So that didn't really leave me with much choice. But I thought I'll start with the patron saint of dentistry, who's not very far away from where we are in Alexandria. This is Saint Apollonia holding a pair of forceps, extracting an extraction. This was going back in the 2nd century, year 249 in Alexandria. She's venerated in the Coptic and Eastern Orthodox Church, as well as the Oriental Orthodox and also the Catholic Church. And she passed away in Alexandria. As you could see, they're being tortured by having all her teeth extracted or shattered. The feast is celebrated in the Coptic calendar, and I believe the way to pronounce it is Imshir, the 2nd, and this is February the 9th. So she's a Saint Apollonia, and this is a well-known saint in our Coptic church, and I thought it was appropriate to put this as she is the patron saint of dentistry. This is my dad. It is a blessing to be able to help others, and it is an honor to be part of a group of people who care to make a difference to people's lives. This is something that my dad has brought us all to be able to do for the rest of our lives during my training and everything else I do on a daily basis. You always have to be thankful to God. This is my lovely family, my mom and dad, my wife, my brother, and the rest of his family, that's his wife. And of course, you all know Abuna from our lovely church. This is my adorable family, who I would say suffered with me along my path. Sophie is our youngest one. She's into football, not quite into rugby yet. My wife, and that's them when they were little and before they became naughty. Katrina is into the outdoor activity, and this is my long-suffering wife, Sam. I thought I'll put these pictures in because I felt blessed to be surrounded by lovely people. This is my work family at work at St. George's. I'm currently the clinical lead. but you've got the first row here is all the consultants, and then further at the back there's further other consultants, and the rest of the team makes you feel extremely comfortable on a day-to-day, makes you enjoy coming to work. These are the hospitals I work at: St. George's, Ashford, St. Peter's, also work at the Leicester in Chelsea and Parkside. St. George's dates back to 1750, and I don't know whether any of you know the old site is at the Hyde Park corner. Sorry, not Hyde Park corner, towards the Victoria roundabout. This is the old site, and in fact, if you observe the writing up there, it would say St. George's Hospital. And the current site, which is just a few minutes away from Wimbledon, is this big statue of Jenner, Edward Jenner, who you might not know, but he was the first person to have developed the first vaccine. And he was educated at St. George's Hospital. We have a helipad, and some of you may have seen some of the programs on TV, the 24-hour stuff, and we were filmed there a couple of times looking after facial injuries. My work family at Charing Cross also is another hospital when I was appointed at Imperial. Again, you peer out of the window and you sort of take a fresh air and you look at the wonders of God's creation and how you're part of it. So my career background, sorry, I'll go back. As you all know, started in dentistry. I qualified as a dentist in Liverpool. That's going back to 1987. I then worked in oral surgery and then subsequently maxillofacial surgery, got my fellowship, went into medical school, did general surgery and accidents and emergency, orthopedics, vascular, and of all things, colorectal surgery. Don't know the relationship between that and maxillofacial surgery, but it really helped instill the basics as well as the core training in being a general surgeon. Subsequently, I got my surgical fellowship and then specialist board exams of the fellow of the Royal College of Surgeons in maxillofacial surgery. And that took me through working at St. George's, Northwick Park, Kent and Canterbury, East Grinstead, St. George's again, Royal Surrey, and various other hospitals in between. Finally, I was appointed at Imperial in London. That was 21 years after having all these qualifications. And then subsequently became a consultant at St. George's Hospital because it was nearer home. And now I'm currently the clinical lead. So as with any surgery, you're going to see before and afters. But before I move on to this, there is something I'd like to show you all. This is the before. That's my office after doing all these exams. This guy here is hired by my wife, so to take up and clean all the stuff that I managed to destroy in my office. And then this is the office afterwards. That's where I am now, thankfully. So there is a before and after. But what you will see now is some slides from the areas of interest that I have. In maxillofacial surgery, you can branch out in many wonderful things, from head and neck oncology to deformity, reconstructive, facial plastics, temporomandibular joint surgery, trauma, cleft lip and palate, craniofacial, surgical dermatology, which is something Abuna Daoud had experience of in his career as a dermatologist, and oral medicine, oral surgery, and salivary gland surgery. Going into the next slide, I've listed the areas which forms the basics of what my practice is. Mainly now it's focused on TMJ surgery and joint replacements, as well as skull-based surgery, obstructive apnea, reanimation surgery, and a lot of the facial plastics and deformity. So I thought of how can I make this comprehensive enough to show the group how I could contribute. And if I may just share with you some interesting cases. So I've listed them here: facial pain, which you all see as dentists, painful jaws, jaw joints, painful as in clicking joints, and so on. Some of them might feel that their teeth are not meeting together. That's malocclusion. You also see that. And some of you are orthodontists and would would be working in a joint capacity with people like ourselves in maxillofacial in joint orthognathic surgery, and may see trauma, dentoalveolar trauma that extends beyond the dentoalveolar complex to involve the maxilla, the mandible, the jaws, the joints, the eye sockets, and so on. Also, some of you may also contribute to people who snore by using splints to move their jaw forward so that it allows them to breathe. I'm going to brush in, and show you what sort of development I've made in surgery for people who have obstructive apnea. And then finally, other avenues such as facial paralysis, droopy lips, and so on. So let's look at some of these cases. As Sayyidna has mentioned, it's all about collaborative work. In our medical terminology, that's called MDT, multidisciplinary team. And for this to occur, you need to have a number of specialists who are good at doing one thing and bring them together to provide the best service for our patients. So in TMJ surgery, for example, I deal mainly with the arthrogenic people with the TMD. The myogenic and neurogenic people are dealt with by a totally different team, but nevertheless, I talk to the patients and inform them that whatever we do is not like we are able to recreate what God has given them in a joint, but we're only slowing down this slippery slope towards an end stage of arthritis. However, we are able to help them with the pain, and we are able to look at a joint that is normally healthy like this and to try and deal with a joint that is extremely painful and excruciatingly painful like this, or like the one in the slide below, which shows a massive osteophyte. By massive, I mean it's massive because it's a small area in front of the ear and everything is magnified in that area. People with hypermobility disorders can present with all different signs of hypermobility. This is called the Gorlin sign, which is ability to be able to stick their tongue and touch the tip of their nose, and they have hyperflexible joints. These groups of patients have got a disc that dislocates. You can see a normal side or inflamed side is compensating, other side is scarred, and you can see your chin deviates to one side. This patient was diagnosed with arthroscopy, but was thought to be crazy in the head, coming in, able to open her mouth, her jaw deviates, but everybody said, oh, don't worry about it, it's click, or give them a splint. That's the wrong thing to do. As dentists, you should give a holistic approach and consider what could be the sign here that's making the chin go to the one side. Some patients can present with inability to open their mouth, and believe it or not, this torture device was given in the past where you're able to put it in and screw this until you wedge their mouth open. Now, quite a lot of these patients present with dislocated discs that don't reduce, or with severe arthritis like the pictures you saw earlier. But this is my pathway. I look at things and be able to do, provide arthroscopy, washout like that, wash out the joints. Also looking at needle arthrocentesis, as well as a TMJ arthroscopy using the Biomet on point. And it's a small area, and I can play this video for a little bit, but I'll speed things along as we want to catch up with time. But when the patient opens and closes their mouth, you can actually see the two joints coming apart there, and you're able to look at fantastic views of what's going on in the joints. Arthrocentesis. This is the washout. We look at the video here. You can see that's the condyle, and you can see an osteophyte at the posterior medial side with the. So you could actually see things inside the joint. Another avenue that you may be facing in your practices is to inject these muscles with muscles of mastication, with Botox. And this chap here who shattered his teeth, you could see the effect of the muscle spasm. You could see the large temporalis here. And one of the things that responds well to this is in this group of patients who are diagnosed with myogenic TMD is Botox. Okay, so we give them injections. You can see here he's going through the spasm stage. He can't control it. Look, he's actually not doing this deliberately. This is happening every now and again, and his teeth just locks. This chap was so happy after he is able to open his mouth after injecting. You can see the flattening on one side compared to the other. I gave one side as diagnostic to see the effects. This is another girl. I've known her since she was 13, 14 years of age. This is now 9, 10 years later. And you could see the enlargement of her masseters compared to the other side. And this is now responded well. And she's now in her 20s with normal, non-tender muscles of mastication. Now comes the gory bits, which includes things like a condylectomy, removing condyles. You could hardly see the scar. I make an incision in front of the ear for this. She's showing you here. Patient is able to then open their mouth and you remove the obstruction. This patient was referred to me from head and neck oncologists. You could see one side is paralyzed. She's not able to raise her eyebrow, and they put in a replacement that became Angaelos. Bone grew over it. Those of us who are not medics or not well into this field. So she couldn't open her mouth. That was it. So she came to me. I did 3D volume analysis of what's going on and also planned a replacement. So I placed the joint replacement here. All you see, these clips are on vessels that she'd had when she had her head and neck surgery. And that's the replacement in place. By the way, you don't see the top bit because it's made of plastic, but you can see a silhouette there of the shadow of where that socket is. That's what it looks like. I also managed to plumb the mesenteric nerve, which nerve supplies the clenching muscles to the facial nerve, and allowed her then to be able to smile. She's able to smile and back to normal, hopefully, like you saw on this slide, and is able to open her mouth. I see a relatively large amount of golden heart syndrome patients, and this is one of them, quite significantly deformed jaw. I may be able to look at a concomitant TMJ replacement as well as a bimaxillary osteotomy to correct this maxillary cant, which is a tilted jaw and a very much deviated chin. You could see here that's not a normal jaw, that's a rib that's put in since childhood, and you could see it's fused to the skull base. So this was a case of me having to release an ankylosed bone or rib that has joined the skull base, where all the important structures goes to the skull base. This is the planning of this patient, where you can see a unilateral sagittal split, an axillary Lafort 1 shift to the opposite side, and extended the replacement after removing part of that rib and released it from here, and then a glenoid fossa reconstruction, which you could see here. So this was him before. He's had multiple surgeries, so this area was challenged. And you could see what his bite looks like. You can also understand why we need to do dentistry as Max-Fax surgeon, not just general surgery, but Max-Fax surgery. Here you could see all the vessels going up and down the neck, plus the nerves, plus all the important structures, including the facial nerve and the ankylosis to the skull base and the closeness and proximity of the ear. And obviously this was a very challenging case. These are the bony saw cuts, so you're sawing through at Lafort 1 level, the skull, the mid face of his skull, as well as his lower jaw. Here is after correcting the chin. You could see at the end of surgery, you could see the teeth are joining together nicely. And that's us working as a team. Again, it's collaborative and it's a multidisciplinary. These three are all my registrars, and they've all become consultants at various hospitals in King's and around London. And this is the young man. This is the before surgery. And this is after surgery with the replacement and the teeth straighter. Again, you might see something called condylar resorption. This older gentleman has noticed that he has developed a gap between his front teeth. And you ask yourself, you know, what's going on? Is his teeth moving? Is his condyles resorbing? And then you take a scan, and certainly it does show that he's undergone resorption and the tilt of his maxilla. So again, very similar. You plan these cases in Florida, virtual surgical planning, and you do the surgery by opening up in the frontal area here, lateral area, as well as the temple and in front of the ear. You've got a bridge of tissue which has got houses the facial nerve in between them, and then you make a cut in the neck, and that allows me access to go from below. So you've got control from above and below. This is his open bite before. This is what's going on with his joints. They've almost collapsed and completely resorbed. And here you could see that as a result of this resorption, you ended up having no hope in restoring his joints, but to actually help in releasing the problem and putting in new joints, and then Bimax osteotomy. That's what it looks like, the replacements, and that's him afterwards. The scars have settled nicely, and that's him. You could see when his back in clinic is able to open normally, and when he closes, you could see his teeth don't show a gap. Again, challenging cases with a big tumor in the skull base, again, affecting the jaw joint. I don't want to bore you too much with these cases, but this one was quite a horrendous case. And I thought, my goodness, you know, to be referred this by your own consultant who taught me, felt as either a suicide mission or a blessing from God that, you know. Here you can see the tumor has eroded through the skull base. And wait and behold, you see a big foramen here and one here, which is your carotid channel. And this is the foramen ovale. For you of you who know the anatomy, this tumor had eaten almost the skull base. That's her. And when you look at the patient afterwards, she's able to smile and raise her eyebrows, and she's able to move her face and the smile, and she's able to have her teeth back in normal. So it's all about collaborative work, joint orthognathic clinic. Other things I do is facial deformity, which is partly cosmetic, partly to allow people to bite together properly. And these patients normally require just a straightforward orthognathic level advancement or rotation or impaction, as well as mandibular advancement or setbacks. This is what they look like with plates afterwards, but you go from that to that, and it does change their lives. You're sort of looking at these patients with, you know, with joy, knowing that they are able to eat properly or have a normal life. Another area that I deal with is trauma. And when you look at facial trauma, is one of those things that, let me see if I can play the slow motion. Here it is. So watch the punch coming in. This is a guy that gets punched in the face. And you could see on various views on this. I don't know whether it will play this time or not, but anyway, it had a box, and you could see all the bones in his face actually shatter, and without any sort of imagination of what gets fractured. You need to scan the face and be able to see things in 3 dimensions. And here you can see the dent, from a simple dent in the forehead to one that's involving an eye socket. This is the dent ironed out, you can see here. And that's him after surgery. But I hide the scar up here in the scalp, and you could see it's sort of a reconstructive craniofacial part of surgery here. You could see part of the dressing. Others would need a plate under their eye socket. And this is something that one can help with in terms of helping people with orofacial and orbital trauma. You could see the eye socket is gone. Here, the eye drops down into the sinus, and you're able to lift it and create a 3-dimensional image of the eye socket and be able to restore it with a plate made of PEEK, inserted under the eyelid through an incision in the eye, through the eyelids. And here you could see what we started off with, what we ended up with. and here the eye, which is sinking down to move it to this. So really, you know, orbit surgery is another big area of ours. I'm going to speed through the slides because I'm mindful of time and I need to finish in about 10 minutes. So sleep apnea is another area I took my interest. There is a lot of vast things I want to share with you, but people who suffer with sleep apnea are stop breathing at night, and this releases the adrenaline and gives them a potential risk of stroke, cardiovascular disease, diabetes, and all the problems that are associated with cortisone. This is the guy before. He's a headmaster, and you could see how his airway is narrowed, and he's got a retruded jaw. Here, after surgery, you could see the airways opened up because I lengthened the jaw and moved the mid-face forwards. And you could see the step going almost like 1.5 centimeters forwards. These are various patients who have had the same surgery, and you could see it does change their lives, and they are cured of sleep apnea. You could notice the chin-neck distance being changed in these patients, as well as the relationship of their teeth. This is similar cases again, and it does sort of take 10 years off them, and it's nice to be able to say I'm cured of apnea, and be able to send you pictures of their loved ones enjoying a different lifestyle and so on. It is through hard work with my colleagues, and work with my registrars in planning these cases, and also not to forget mentioning all the allied specialties such as the respiratory physicians and so on. And now one of the final pictures is the skin cancer, and I'm sure Abuna Daoud, if he's there, he might make comments. This is a chap who has an SCC, a squamous cell carcinoma, causing tethering of his eyelid. And I did surgery, which is involving half his face to move it towards the medial side. After excising this big, massive SCC, you need to take it out with a margin. And that's him showing the ectropion is sorted and the cancer was completely excised. This is a dear friend of ours from our church who's diagnosed with also an SCC of his lower lip. And after removing half his lip, I did a transposition flaps and advancement flaps, and that's him immediately after surgery, and that's him at 3 months, cured of his cancer. This is another patient who has skin cancer again at the forehead. You can see her hair here. I created a pocket to place some rib, which I harvested from her chest, and be able to then turn it round from this forehead flap into a nose. That's her at about 2 months or 1.5 months, I think, and so on. So I could go on, and I think I may want to stop there if you wish, and show you a final picture. The final picture is one of facial paralysis, showing this lady here who was unable to blink. And one work that I do is to swap over the muscles in that eyelid and put it onto the muscles of the eye that's not working. And if you, like a tongue. That's her, you can see blinking.
Close your eyes. Excellent.
And
Open.
you can see maybe a slight smile as well there, early.
Excellent. And again?
Okay. So there are areas in maxillofacial which actually brings a smile to my face. And I always feel that I'm blessed having been given support. So this is another slide, a lady with paralysis.
3 weeks from today.
And she couldn't, as you can see, she's not able to, and she's able to smile. And again, this work requires taking flaps from elsewhere in the body, plumbing it in to the muscles that don't work with the nerve, and allowing them to smile. Implantology, which is something that Rafiq will be able to speak about a lot more, but in dentistry, this is as close as I get. So I do apologize that none of the others had much to do with dentistry, but there was, for those who have specialist interest in orthodontics, orthognathics, TMJ, and so on and so forth, that this may make sense at the end. So people who haven't got any bone, I'm able to place a zygomaticus implant. Obviously, you're aiming to put that implant from the mouth into the cheekbone. And this is through placing 4 implants. So like this, and you can see how it is inserted. The restorative dentist is able to put these implants in. I put these ones in for him. And you could go through all the prosthetic bits, which I can't remember how it's done, but this is a dental bit that you guys are much more familiar with than I am, and be able to then put teeth on it and give her a change in her smile, as well as biting and so on. Those of you who are interested in zygomaticus implants, I was chairing a meeting at the RSM, and this chap here is Italian. His name is Andrea Tedesco. Not known to myself, but recently, or rather in the last 5 years, he's written several books on zygomaticus implants and would welcome anyone who wishes to learn about zygomaticus implants to go over. I was the chairman, and I gave him a certificate, and he was an absolute delight to know. A cancer in the nose can be also dealt with in the same way. I was able to put in zygomaticus implant and place another implant in here to reconstruct this type of setup and be able to make a nose and be able to then restore nasal. You could see the joint between the artificial nose and the lip here. You could see the joint here. Okay. And I had the similar idea to try and do that for our Abul Hol, but they wouldn't let me in Egypt. But that was, this is what I was imagining. And I think that was the end of my talk. I thank you all very much for listening. Sorry, it was a bit rushed, but I tried to catch up with the timing. Thank you.
Thank you very much, Ashraf, for that very interesting talk. Lots of interesting cases, which I'm sure we'll probably never really see, but we might be referring to you. We have one question for you, if that's okay.
Christine, could I jump in for a minute before the question?
Yes.
Because I'm still here. First of all, Ashraf, thank you so much. I actually stuck around.
Oh, thank you. سيدنا أنا أخذت بركة كبيرة كده سيدنا وأبونا داوود يعني I'm so grateful.
Oh, it was wonderful. I mean, I consider myself part of your family, Ashraf, because I met your kind parents the day I came to receive my service in the UK 25 years ago on the plane. So I consider myself part of that. Just 2 quick things. First of all, I love the corrective service on the Sphinx. And secondly, I'm so glad that guy being punched in the face didn't work. I don't know if I would have been able to handle that. But I just wanted to sign off and say thank you, Ashraf, and thank you to you all. And I'll leave you to your questions now, and I look forward to working with you all.
Thank you. Thank you, Sayed.
Bye. Thank you, everyone.
Thank you. So we'll start off. There's one question for you, Ashraf, if that's okay.
Yes, of course.
So we've got a question here from the GDP perspective. How can dentists help with TMJ problems in dental practice? So which appliances, if appropriate, should we start with? Okay,
that's a very good question, and I sort of gave a quick slide on making the appropriate diagnosis, which is one, you need to ask yourself, is this myogenic, arthrogenic, or neurogenic temporomandibular dysfunction? If there is a combination between a myo-arthrogenic or a myo-neurogenic or whatever combination it might be, you need to ask yourself, what element is it got to do with the patient clinching, i.e. only purely myogenic? Because if you give somebody a rubber splint, for example, who grinds their teeth at night, they're going to chew through that splint. They're going to come back with worse symptoms because the pull on the disc is such that it pulls the disc then dysfunctionally out of the way, and it becomes then a myo-arthrogenic problem, because then the disc dislocates, it may not then reduce, and then you've got bone-on-bone non-reducing dislocation and deteriorating signs of arthritic joint. Whereas if you thought about this initially and looked at what type of treatment as opposed to what type of splint, then you would have come up with the right diagnosis. Do splints work? Well, then you have to revert to the NICE guidelines and the Cochrane report. With splints, in my opinion, the rubbery ones in clinchers does not work. In fact, in my opinion, looking at 2,500 patients, does not work and makes the situation worse. I deal with a number of litigation cases where this has happened, and I have to give an expert opinion and base it on best evidence, current best evidence. And the splints that do work, in my opinion, after everything else has failed, is something called an NTI splint. Some of you have heard of it. It's a nocturnal trigeminal inhibitory splint. And some may have heard of other types of similar splints, like hard splints. They then work on the workup of a problem with patients clenching hard. They then create pain that sends a signal to the brain, that then the brain sends a signal for these muscles to relax because it hurts. So it has to then hurt the patient in order for it to open the mouth or to relax the jaw through conditional reflexes. So they either going to chew through the splint, and that's a bad thing if it's rubbery, because their condition will get worse, or you give them a splint that will hurt them. And so don't just dish it out, wait, give it for 5-6 weeks period, and if it doesn't work, then you need to look at an alternative very quickly, such as cognitive behavioral therapy or acceptance behavioral therapy with psychologists. There is a reason why they just clinch. But I don't normally see these patients who purely are myogenic. I only see arthrogenic with completely damaged joints and ones with quite a significant degenerative arthropathy.
Thank you. We have another question, slightly unrelated, but potentially, Ashraf, you might be able to help. It's from someone asking for advice about starting a Max-Fax junior SHO or DCT job.
Yeah.
What would be your advice? I think you're best placed to answer this question.
Sure. Well, I'm glad there is somebody interested in Max-Fax. Always brings a smile to my face. I'm trying to get our Georgina, who's a dentist, qualified this year, to do the same. She's probably in the group. In Max-Fax, that slide that you saw, I hope it didn't frighten you. It did take us in the past 21 years. It doesn't anymore. We are now more focused. We provide this whole program within a number, maybe 8-9 years less than what I had to do. Starting from medical school, I did medicine in 5 years. Now medicine is done as a dentist in 2.5. As a DCT in dentistry, I did 3 years, and that is to become core trained in being able to manage trauma and fix orbits and so on. You don't need that anymore. You need to just have done DCT 1 and 2. So to just give you a taste of what maxillofacial hospital work is like. So I suggest you start there. Start with seeing what hospital career is like, working with patients, looking after patients, becoming responsible for medical conditions of patients, and realizing the need to do dentistry, to do medicine alongside your dental qualification. Then there is a bunch of exams. Loads and loads of exams. So your MFDS, they're followed by medical school year after year, then followed by general surgical training, and then fellowship in general surgery. And then after that, specialist training in maxillofacial surgery. And what I'm trying to do here is, working for the School of General Surgery, is try and shorten the course for people who are undergoing training, dual qualification. So it is a lot shorter than during my time, but you need to have a focus, and it needs to be a passion to do the things that I hopefully tried to show you today, ranging from like orthopedics, this is orthopedics, putting a joint replacement, to cancer work with reconstructing the face, to plastic surgery, to dermatology, to things like giving somebody a set of teeth to bite on. You might take it for granted, but some people with no bone have got no hope at all to have dentures. And so you might be able to put in zygomaticus implants and what have you. So the wide range of things that you may be able to offer patients with dento-orofacial anomalies is there. And you just need to make sure that you're doing the right thing for the right reasons. You're doing it to help and to be there for patients.
If I can also add, I've had a little bit of, I've had 4 years of experience as a Max-Fax SHO. And although I'm not currently going down the Max-Fax route, it has really significantly helped me in lots of things. And that includes sort of decision-making, time management. You know, as an SHO, you'll be asked to do, you know, millions of jobs. It almost feels like you have to do lots of things at the same time. So it's really helped time management, as well as everything you said, Ashraf, to do with the how medicine relates to how you treat a patient as a whole, really. So that's my
thank you very much,
at
Christine.
the end.
You know, I'm glad you're pursuing your dreams of, you know, we work very closely with our oral surgeons, as I mentioned. You know, these guys do rehabilitation work, orofacial rehabilitations for cancer patients. So people who have had resective surgery, cancer resections, have half their maxilla removed, and we, you know, there is a whole lecture on this I can share with you, and maybe do a double take with Christine, who's you know, looks like, you know, this is the type of work she'll be doing once she's finished her training. But yes, it's quite a significant sort of career pathway, and it isn't easy. Yes, it's difficult, but it's full of joy.
Absolutely, absolutely. Thank you, Ashraf. I think that's all the questions regarding your talk. Thank you very, very much for taking the time out of your busy schedule to do this talk. And you've had some comments saying it's been fascinating. So thank you very much.
Thank you.
I'll hand over now to Mariam to talk about a bit more about the charity side of things.
Okay, so hi guys again. I'm just going to summarize a bit about what you guys can do to help us. So we're currently raising money on our GoFundMe page for the charity work in Egypt. So the link will be posted on the chat here, but also on all our social media platforms. And really, any contributions are really appreciated. If you are donating from the UK, then just make sure to click the gift aid button. That's just going to add a bit more to the donation without actually charging you any extra for it. So that's good. But yeah, donations aren't the only way you can help. Like if you know anyone that's able to donate supplies, so toothbrushes, toothpaste, or even put us in contact with companies that are able to do that, just let us know. And if anyone's interested in lecturing for our future webinar series, let us know as well. And I just want to thank you everyone for like joining us, and it really like wouldn't be the same without all of you and all your help and all your support. So yeah, thank you so much, and I'll pass you on to Andrew now.
Thank you, Mariam. Just a quick note on the social media. So first, I just want to say massive thank you to everyone who's followed us, sent us lovely words of support, and offered their help. It's really inspiring to see how people want to get involved, and it's motivating us to keep going and growing as well. If you haven't already, please follow us on the Instagram page at Coptic Dentistry and share it with your friends, family, and the colleagues who are interested in our charity work, and anyone interested in joining the society either. We've also recently set up a new Facebook group at Coptic Dental Society, so you know, add yourself on there, and we'll be using it as a more informal way of connecting with everyone. We'll be posting case studies, which should be interesting. So some from today, the OMFS ones, and then possibly PROS, peri ones, and different ones as we grow, and that'll be nice for dental students and more specialist type posts as well for people later on in their careers. Because we're also quite young and we're evolving, if anyone's got any ideas or anything, any opinions on the charity work or any way of fundraising, get in touch with us, and we'll be taking any new ideas on board. And if you have any questions, also you can contact us through our email on there as well. And yeah, massive thank you to everyone who's joined us and everything, and hopefully we'll be seeing you all very soon. I'll just hand it over to Rafiq for a final few words.
Can I just add as well, Andrew? So we're also going to send you guys out a feedback form after this meeting. It'd be really helpful if you can all just fill that out, and also just leave any comments or suggestions. We'll welcome anything, to be honest. You know, if you think that there's something we've not mentioned that you can bring to us, we really want that. So we really hope that you guys all can reply with that feedback.
Right, thank you guys. Thank you for joining us. It's been really lovely having all of you, and it's nice to see dentists all over the world, coming from America, England, Bolivia. I think there was one from Bolivia, Egypt. So all over the world, we're just gathering together. And this is not going to be the final meeting. We're going to be having regular webinars. We are planning our next one to be on the 18th of September. It's going to be a Saturday as well. We want to hear your feedback if the timing that we're doing suits everyone or not. So we thought about this time to suit people in England, in America, it would be in the morning, in Egypt as well, Easter time, it would be early evening, so it should be fine. So we want to stick with Saturdays. If you've got any other ideas, please let us know. As for the charity, how can we move forward? First thing, we are going to be starting by the donations. The actual mobile car that we're thinking about to start with, it cost around 50,000 pounds, English pounds, which is close to, I would say, $60,000, $65,000. We have managed to collect some of it now, but we are still far from it. So we're still gathering money. So I would encourage you all to go on the GoFundMe page, donate, and then we will update you bit by bit how much we gathered, and we transform the money to Egypt to put into the funds for this car. Again, if you cannot donate, if you can pass on the GoFundMe page to anyone that you know, friends and family as well, that would be great. Second, we will be, once the car is set up, we will have some dentists of us just going to Egypt to do some dental charity work in Egypt in this mobile van and in all clinics that Abu Daoud mentioned before. So whoever is interested, please show your interest by emailing us, and we'll just take note. And once we will be starting going our first, after the whole COVID-19 is over, we hope that we would arrange something in the near future. So yeah, our next webinar is on the 18th of September, and we hope to see you all there. Anyone that think that they can be part of these lecturing and he wants to give a lecture, please come forward. I know that within us is Wael Yegas. He's a specialist orthodontist. He's the one that taught me implants as well at Eastman Dental Hospital. So I'm sure that we will be quite honored to have him once and to give us a talk about all his interesting cases as well. Do post your cases to Andrew and John, because possibly they will start posting it on the Instagram and the Facebook, so we can just share knowledge all together. Right, thank you everyone. Thanks Ashraf, and thanks to all the team.
Thank you.
Right, okay,
Well
so
done.
we'll see you on the 18th.
Thank you.
Bye.
Bye-bye.
Thanks everyone.
Thank you everyone.
Bye.
Thank you.